Bye. Welcome, everybody, to Knock Knock Eye with me, your host, Dr. Glockenflecken. This is your one-stop shop for all things eyeball related. So we're going to do a couple things today. We have a little AI discussion because there's a recent story in the news about a prominent CEO in the US basically saying like he's ready to replace radiologists with AI. So we're going to dive into that, which is making the rounds on social media. And then after the break, we'll go with an ophthalmology thing I love and an ophthalmology thing I hate. We got a couple good ones today. All right. So first, let's jump into it. Radiology. So I remember when I was a pre-med and thinking back on this time, which was 2006, 2007. So a full 20 years now. I kind of remember how like neurotic I was and like the anxiety and about like just being able to like, first of all, just get into med school, but also like what specialty to choose, because at that point I had no idea. And so I would I do the one thing that you're like never supposed to do, which is go to studentdoctor.net. You guys remember that? I don't even know if it's still a thing. I haven't been to that website in like, I don't know, 18 years. And so if it's still a thing, it's full of everybody with that mindset. Like everybody's nervous. Everybody's just not sure about if they have a strong enough application, what specialty is a good specialty. But one of the recurring themes that I remember being discussed is AI going to replace radiology? I don't know if they said like AI, but it's like, is it going to be automated? Are radiologists going to be out of a job in 5 years? Like, and this was 20 years ago. I remember people talking about this. So before OpenAI, before Claude and Gemini, all these things. And so fast forward now 20 years later. And we are in the situation we're in where we have like 4 or 5 big players in AI. And the tech people that own those big players it feels like just really trying to convince all of us that this is going to be a great thing. And so there was an article that I read in Radiology Business. I'm sure it appeared elsewhere as well, but CEO of America's largest public health system says he's ready to replace radiologists with AI. So Mitchell Katz, MD, who is the president and CEO of NYC Health and Hospitals, which is the largest public hospital system. So like not just anybody, like this is a major player in healthcare. Basically saying that we could, his direct quote here is, we could replace a great deal of radiologists with AI at this moment if we are ready to do the regulatory challenge, which basically means just make it like legally okay to do, I suppose. And on the one hand, you could dismiss this as just another kind of, I mean, it's not fear mongering from the perspective of a physician, but kind of blowing. You could blow it off as like, there's just talk. Like, AI is not where it needs to be just yet. And then the other side of the coin is it could be like freaking terrified by this statement, because this isn't just like a tech guy. This is a CEO of the biggest public hospital system. And CEOs make these types of decisions. I've been talking about it over down in Eugene, Oregon, where they just decided not to renew the contract of the local group and give it to this corporate agency, right? They make these types of decisions. And so I think it's silly to just like blow it off, because CEOs are thinking in this way. It's like they're just waiting for it to be, I don't know, socially acceptable to make this change, as if they would care what society thinks. or maybe they're just waiting for the right moment where legally they wouldn't be sued. Or, I don't know. I don't know what's stopping them, but they're clearly like ready for it, which does worry me. Now, one of the big questions is like, is this actually a possible thing from like a patient care standpoint? Because that is the mindset that all of us in healthcare who see patients, all physicians, that's where we come at this. Okay, like, do we know that it's actually going to do a good job? And to be honest, like, this is not my area of expertise, so I honestly can't speak to like the data that exists right now for radiology in particular. But let's just look at the job of a radiologist, because I feel like so many people, especially not even just outside of the healthcare space, like people that are in the tech space, but also just even non-radiologists, even physicians probably don't really understand what a radiologist does. And a lot of people just think they interpret images. That's it. You give them a random image and they will say, this is wrong. This, look at this finding, and just list it out. And that is an incredibly reductive, simplistic view of what a radiologist does. But I think most of the people who are like pushing for AI to replace radiologists think about radiology that way. Can an AI program take all the clinical information, the entire clinical picture of a patient, prior surgeries they've had, prior diagnoses, prior cancers, and put that together with an imaging study that might not be even a great study? Maybe there was movement, maybe there's artifact. Put the entire clinical picture together, what the prescribing doctor who ordered the image, what they're looking for, what their question is, and then what the image shows. Can an AI program integrate all of those things and then produce like a high quality reading of that image? I'm partly asking, but I'm also skeptical that is actually happening right now. Or is it just pattern recognition? Because yeah, that's part of a radiologist's job, but that is not everything. And so I and most of my physician colleagues, I would say, are skeptical. But we are also looking at it through a lens of what's best for patients. And so if you ask, would this change, getting rid of radiologists and just letting AI do this, is that good for patient care? I would say right now the answer is no. And probably for a long time the answer will be no. But physicians are not the ones making these decisions. It's administrators, it's CEOs. What do they care about? Because ultimately that's what matters. We have lost so much agency, physicians, healthcare workers, that this is kind of out of our hands. Now, this CEO I just quoted is a physician, ironically. So, hopefully he's got a little bit of that in him, but doesn't sound like it. And so, and we know that CEOs, we've seen time and time again, there's a lot of dumb ones out there. There's a lot of idiots who are not thinking that way. They have stopped thinking like a physician, even if they are a physician. Or they just have a business background. They run it like a business. All right. And aren't thinking of the human component to this. And I'm not talking about like saving radiologist jobs. Like, yeah, I'd love to save as many radiologist jobs as possible, but we're talking about patient care because that's where we're coming from. But I would say time and time again, they've shown us a lot of hospital administrators are not coming at it from that standpoint. It's dollars and cents. It's efficiency. To hell with doctors. So the pessimistic part of my brain thinks that this is how it's going to play out. And other people have said this too. So this is not my idea, but I I also think that this is correct in that these hospital administrators in high position, they're so accepting of AI. It's like this train that's just gaining steam. And unfortunately, I can totally see them accepting AI as an adequate substitute for radiology. But the problem is, and we're talking about finances, because someone has to be on the hook for mistakes. Somebody has to be on the hook. And hospitals, CEOs, they are not going to want to accept 100% of the liability for stuff like this. And the AI companies are not going to want to accept 100% of the liability on this. They're not going to want to accept anything. There's going to be all kinds of legal paperwork and waivers and things to defer all the liability from the AI. You're not going to be able to sue an AI company. That'd be awesome if you could, but I'm taking a very pessimistic view here in that they're going to find a way. They're too powerful, going to find a way to weasel out of any liability. So then it's okay, is it on the hospitals who are buying this AI program to use to interpret all their imaging studies? Well, hospitals aren't going to like that because that's a hefty amount of liability. Because we're talking about missed cancers, missed strokes, missed brain bleeds. Huge potential for liability. So here's what I think is going to happen. They're going to make the change. There's going to be like one or two hospital systems that are going to go for this. They're going to do it. They're going to basically let go or fail, not renew the contract of whatever radiology group they're contracting with. And they're going to start using AI. And they're going to hire one or two or a handful, maybe a few, a much smaller radiology workforce, physicians. Those are the ones who are going to be on the hook. And they're going to make decent money. There's just going to be fewer of them. But their liability is going to be massive because it's going to be on them to be a safety check, a quality control of thousands of AI generated reports. And once you have AI doing it, the throughput, imagine how many studies you can do. You can do thousands more studies, assuming you can find the staff to actually perform them on the patients. And so you're going to have a handful of radiologists on the hook from a liability standpoint for an exponentially higher number of studies that are done in this type of model. And private practice radiology will wither and die. I'd say that's worst case scenario. I don't see anything that's going to be like radiology as a career option is going to go away. No, we're not. That's not going to. If that happens, it's going to take 100 years. All right, no. But I could see this happening in the next 10 years, and that's kind of scary because fewer job opportunities. I think we're going to see a lot fewer med students pursuing radiology. Even if none of this comes to fruition, just the threat. Going back to my pre-med message board days on studentdoctor.net, the fear is going to drive people away from radiology. That's what I think is going to happen. I might be wrong, and I hope I am, by the way. I hope I am. It was easy 20 years ago to just AI replacing radiology. Come on, a computer reading all these images. No, that's silly. That's not going to happen. And it just died right there in the message board. Now it's it feels like enough momentum to actually for something like this to actually come to fruition. And then, and then eventually, do you have an AI program that can do all those things I mentioned that is actually a radiologist job where you're synthesizing complex clinical history with prior imaging, prior procedures, all these things together, physician questions coming at the radiologists. Is it able to synthesize all this stuff? Well, then yeah, we're talking about actually replacing radiologists, but I don't think it's there. And from talking to some of my radiology friends, I don't think they think it's there either. I don't know. A lot of nervous folks, though. It's this. People are getting a little bit nervous, and physicians are going to fight. And it could go the way I just described, where you got a handful that are like the taking on the liability for AI radiology, or we could actually get some like data before people jump to this type of model to see do we have any head-to-head studies, anything that to really show that this should be the standard of care? Let me know, because I haven't found it. I haven't come across it. I don't hear people talking about it. I feel like if there's a high quality study looking at this, like it would be making the rounds. It'd be talked about. So, it's concerning, but like we can still pump the brakes a little bit on like the doomsday scenario where AI just replaces the field of medicine. But it does seem like radiology is more vulnerable, I would say, than other specialties. That doesn't make the rest of us safe, but we'll find out. All right, let's take a break. We'll come back with some ophthalmology. Hey, Kristen.
Yeah.
Be honest. Do people think about their eyelids?
Honestly, I don't,
Okay.
unless something's wrong.
They should, because eyelids are amazing. They distribute your tears. They protect you from incoming objects. They're really important for overall eye health as well.
And we both know they can also be affected by something very common, Demodex mites.
Oh, yeah. Demodex blepharitis.
That's
when
right.
Demodex mites overgrow and they start causing problems like itchy, red, irritated eyelids with crusties.
Mm-hmm.
Collarettes, you got it. And everyone should know that if your eyelids aren't healthy, your eyes won't be either. That's why it's important to see an eye doctor, to get an eyelid check, which is part of a normal eye exam.
And the good news is there's a prescription eye drop treatment available for Demodex blepharitis.
It's great news. To learn more about eyelid health and Demodex blepharitis, visit miteslovelids.com. Again, that's miteslovelids.com to learn more. This ad is brought to you by Tarsus Pharmaceuticals. Hey, Kristen, you know what my mom's obsessed with?
What?
Cozy Earth.
Oh, yes, she is. We have gotten her hooked.
Oh, she can't go anywhere without her Cozy Earth.
One in every room.
Which is fine, because now they got the robes and the slippers.
Yes, we should get her for Mother's Day. We should get that.
That's right. And the robes, spacious pockets.
Mm-hmm.
It's and you can tie it up, and it's adjustable ties too. So it's like to fit you whenever. And it got the slippers.
Mm-hmm.
So you're walking around the house. You're wrapped up in cozy. You're walking on cozy.
You are just ensconced in coziness.
There's so much coziness going on for Mother's Day.
That's perfect.
Like, what better way to celebrate Mother's Day?
Honestly, that's all I want is like a day of coziness on Mother's
Sounds
Day.
Awesome. Let this Mother's Day be a reminder that she deserves care too. Discover how Cozy Earth turns everyday routines into moments of softness and ease. Head to CozyEarth.com and use my code KNOCK for an exclusive 20% off. And if you see a post-purchase survey, be sure to mention you heard about Cozy Earth right here on Knock Knock High, because home starts with mom. Real quick, before we jump into things I love and things I hate with ophthalmology, I made another video about chiropractors. I can't stop myself. I'm sorry. It's just, it makes me so mad. It makes me so mad to see the babies get like people. What is going on in someone's brain to like take money from a brand new parent? They come in with a 2-week-old newborn. Some of these babies I see on these TikToks, these chiropractor TikToks, you have people that are taking money from these parents and convincing these parents that their babies need an adjustment. because of birth trauma or constipation or fussiness, that's unethical and immoral and frankly should result in jail time. And I'm kind of joking, but also kind of not. So anyway, I just made another video talking about that, and the more I keep doing it, the more videos I keep seeing in my For You page, and it's really irritating because it just makes me angry. So, oh man, I think what I'm gonna do. I think I know what my Halloween costume is gonna be this year. I'm going to dress up as a ghost, but it's not like a ghost in the traditional sense. It's the ghost that inspired that inspired chiropractor medicine. I don't even like calling it chiropractic medicine because it's not medicine. It's quackery, chiropractic quackery. The ghost who inspired chiropractic quackery. That's going to be my Halloween costume. All right, let's get into things I love, things I don't love about ophthalmology. So thing I love is a medication. One of the big questions I get asked a lot from people, especially outside of ophthalmology, is like, what eye drops do you use? Because I see lots of weird selections from like folks in urgent care and emergency medicine. Patients come in with sulfacetamide. That's one of the ones I've never once seen an ophthalmologist prescribe it. I've never prescribed it myself. It tends to be a little caustic to the surface of the eye. Don't prescribe sulfacetamide. There's nearly 1,000 better options than that for a topical antibiotic. My go-to, my favorite is ofloxacin. That's great, but that's not the thing I love. I do love it, but that's not the purpose of today's episode. I love erythromycin ointment if you're looking for an ointment. If you want a little bit heavier, heavy duty, a broad spectrum moxifloxacin, that's the go-to. But one very, very wonderful, magical medication that I use often is a little special thing called Tobradex. That is the thing I love that I've been thinking about today because I've already put a few patients on it. It's a wonderful combination, drop or ointment. You get both. You don't get both with erythromycin. There's no erythromycin eye drops. It's ointment or bust. No, with Tobradex. And by the way, I'm not sponsored by Tobradex. I just legitimately love this medication. It's a combination of tobramycin, which is a great, fairly broad spectrum, not the most broad spectrum, but it does have Pseudomonas coverage, which is awesome if you want to use it that way. Tobramycin, dexamethasone. It's great. It's great. You get it as a generic as well. If you prescribe it tobramycin, dexamethasone instead of Tobradex, the brand name. But tobramycin, dexamethasone, you get your antibiotic, you get your steroid. And we use this is where we use it a lot. I use it a lot for people with styes. So a stye is when you have a blocked meibomian gland in your eyelid that causes the oil to build up in the eyelid, and it gets real red and angry and inflamed. And what Tobradex does is it helps to decrease the inflammation, but also can kill off some of the bacteria there. Now, it's not primarily an infection causing this, but tobramycin, dexamethasone, Tobradex is a convenient vehicle to deliver the steroid. And it's relatively affordable as well. The steroids can get pretty expensive, especially ophthalmic steroids. So we use it for styes, just blepharitis in general, where there's just inflammation of the surface of the eye that leads to dry eye symptoms. If you have like burning discomfort of the eye, it's good chance you're dealing with some blepharitis. Those of you with rosacea, you can get ocular rosacea, which causes burning discomfort. Oh man, you guys, you love your Tobradex. Oh, it's great. It just melts that inflammation away. You start feeling better within a day. Awesome. Other uses for this is just post-op inflammation too. Like a patient, I'll give them a little Tobradex ointment at the end of the case. I just did that today as well. And it just helps. It's a great lubricant. And also you get the steroid, decreasing inflammation. Another great use of it is for people with a viral conjunctivitis. Now, viral conjunctivitis obviously is not going to respond to the antibiotic. That's not the reason we're using it. But again, it's a convenient way to deliver a steroid. And so patients who get a viral conjunctivitis are miserable, much more miserable than bacterial conjunctivitis usually. You get a lot more goop and discharge with bacterial conjunctivitis, but you're in more pain with viral conjunctivitis. People get really red eyes, a little bit of discharge, but it's the redness, pain, inflammation. So after a few days, usually I try not to start a steroid for a viral conjunctivitis after patients have had symptoms for at least 3 days, because it's given their immune system a little bit of time to clear a lot of the virus. Because sometimes, depending on the virus, how quickly you prescribe the steroid can kind of like the virus can feed on the steroid, right? So try to wait at least 48, 72 hours. Start a little steroid, start a little Tobradex, and then the patients come back a few days later. They feel so much better, and they recover just fine. So I love it for that reason as well. Now it's not a 100% safe medication, and that's an important point, because you can get steroid-induced glaucoma. So for some people are what we call steroid responders, and we actually don't have a great explanation for why this happens. Some people, when they start taking steroid on the eye, and it's more common to happen in young people. The younger you are, the higher the chance that you're going to have this reaction to a topical steroid. It'll cause the eye pressure to steadily rise. And if that happens, we got to get you off of the steroid as quickly as possible. If we cannot get you off the steroid, we'll start glaucoma drops to keep the pressure down. So that's one downside. Also, long-term steroid use, like we're talking months of steroid use, can cause cataracts to progress more rapidly. And we see that sometimes in people with bad uveitis, inflammatory conditions of the eye where they have to be on steroids. Sometimes we have to put steroid inside the eye, which lasts for months. Usually they end up getting cataracts earlier. Fortunately, we can treat that with a little surgery. That was the topic of the last thing I love, thing I hate I did, which was cataract surgery. So Tobradex. Tobradex gets my gold star of the day. Thing I hate. Stroke. It's any kind of eye stroke, but I'm going to focus on central retinal artery occlusion. Central retinal artery occlusion is one of the more devastating diagnoses that I can give somebody, because it's an occlusion of the major artery that goes to the back of the eye, and most of the time causes permanent central severe blindness. Like people end up with hand motion vision. And it is a stroke. So when these patients come into the clinic, usually I send them directly over to the emergency department for treatment. And when I say treatment, mainly it's just a code stroke. So they're looking at the brain, they're trying to figure out a source for this clot. There's really not a lot we can do in the moment. Now, there's been one time, I think, that a patient came in so quickly that like literally within like 30 minutes of losing vision. And so what I did was I did ocular massage. This is something that you can do that's safe to do. You're just massaging the eye, pushing on it and letting go of that pressure. And what you're trying to do is you're trying to just change the pressure inside the eye to try to move the clot further along the vasculature. Because if you can get it further in to like the really small arterioles, it's going to affect less of the retina and you can preserve quite a bit of vision. And I've seen it work. Like it doesn't always work. In fact, most of the time it doesn't work, but it's a safe, easy thing to do, especially if you're within this like 4.5 hour window. And most of the time, we don't see the patients in time. Patients wait it out. Or we don't know when it happened. If a patient comes in, I'm not sure how quickly maybe they just woke up and it came right in, then we'll do it. And this is something I tell emergency physicians too, that they can do. Ocular massage. Sit there for a couple of minutes. Just massage the eye. And the one time I've seen it work and actually move the clot and restore vision, it's like a miracle. The vision just kind of gradually over the course of like a 30 seconds, it just came back. It was awesome. And so I'm a believer in ocular massage, but it doesn't always work. And it doesn't happen. Those types of cases don't happen enough for us to have data on like how useful it is, but it's better than what we currently have, which is nothing. Now, there was a recent study published in the New England Journal of Medicine looking at using clot-busting medicine, tenecteplase, to see if that can restore vision if you use it within 4.5 hours. And unfortunately, the data does not support the use of this routinely. And so, yeah, it was no significant improvement in visual acuity with or without the tenecteplase. So we're not using the, clot busting medication on central retinal artery occlusions. But we do have to find a source. Emergency department's great at that. We do imaging, looking at the neck, looking at the brain, obviously, to see if there's, because what we don't want is for someone who has a CRAO to have another stroke. And the other thing you have to think about with anybody who has a CRAO over the age of 60, which is going to be most patients who have this, because you have to have, cardiovascular disease, vascular risk factors are very common. Anybody over 60 with a CRAO, you want to check for giant cell arteritis. So giant cell arteritis, another thing I hate, that could be a topic of another episode, is a disease, is inflammatory disease that almost exclusively affects people over the age of 60. If you're 40 and you have a CRAO, it's not going to be due to giant cell arteritis. And the way it causes a CRAO is because you get inflammation in the medium-sized vessels. Typically, it's more like an ophthalmic artery occlusion from an inflammation, from just a big inflamed artery. And the central retinal artery comes off of the ophthalmic artery. So you can have devastating, like no light perception vision loss from giant cell arteritis because it affects the ophthalmic artery, or it can affect the ophthalmic artery. So you always want to check and just make sure that's not a reason why someone has a clinical presentation that suggests a central retinal artery occlusion. So you get ESR CRP, and then if that's elevated, then you basically you got to start steroids, and you've bought the patient a temporal artery biopsy. So find your nearest general surgeon or oculoplastics specialist to get that done. I stopped doing biopsies. Last time I did one was in residency. So yeah, fortunately, one of my wonderful colleagues is more than happy to take those types of cases. So but that can be a pretty difficult diagnosis to treat. Long-term steroids, high dose. But yeah, thing I hate, central retinal artery occlusions. Not a fan, folks. That's it. That's all I got for Knock Knock Eye. Thank you all for listening. I'm your host, Dr. Glaucom Flecken. Thanks to my producers, Aaron Cordy, Rob Goldman, and Shanti Brook. Our editor and engineer is Jason Portiza. Our music is by Omer Benzvi. Knock Knock Eye is a human content production. We will see you next time, everyone.
Knock, knock. Goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen, or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Help you subscribe, leave a comment below. Let us know what you think.